Okay, imagine this. You're heading in for surgery, something that for most people is pretty routine, but not for you, because you have a rare condition that turns the whole thing into a high-wire act. Suddenly, every single decision, from the anesthesia drugs to the recovery plan, becomes a life or death calculation. In this explainer, we are going to unpack the medical playbook for one of the most challenging surgical situations you can imagine.
So, what is this condition? It's called Lambert-Eaton myasthenic syndrome, or LEMS for short. It's a rare autoimmune disorder where your own body is attacking the connection point between your nerves and muscles. The best way to think about it is like a faulty light switch. The nerve, it sends the on signal, but it just can't release enough of the chemical messenger, that's acetylcholine, to actually get the switch to flip. And the result? You get this profound, serious muscle weakness.
And here's why this is so incredibly important. For a patient with LEMS, surgery is extremely high risk. But here's the amazing part. The data shows that with a super detailed, coordinated plan, the risk of mortality can literally plummet from a terrifying 5% all the way down to less than 1%. I mean, that's a huge drop. It's just a powerful testament to how much preparation matters.
So first up, let's really dig into the heart of the problem. What exactly makes this nerve-to-muscle connection so fragile? And why does that make surgery so incredibly dangerous for these patients?
Well, what's really fascinating here is the strong link between LEMS and cancer. It turns out that in about 60% of cases, this muscle weakness is actually the very first clue that there's an underlying cancer, and most of the time, it's small cell lung cancer. The body, in its attempt to fight off the tumor, creates these antibodies that, in a tragic case of friendly fire, end up attacking its own nerve endings too.
So, the whole thing boils down to this communication breakdown. The immune system goes after these tiny calcium channels right on the nerve endings. You can think of them as the gatekeepers for that go signal. With the gates blocked, the signal, acetylcholine, can't get out to the muscle. Now, this doesn't just cause a weakness, it also makes the body dangerously, and I mean dangerously, sensitive to standard anesthesia drugs, especially muscle relaxant.
Right, so because of this extreme risk, preparation is absolutely everything. The medical team can't afford to just react to problems as they happen. Nope. They have to build this comprehensive safety playbook to stop those problems from ever even starting.
A successful outcome here really depends on a whole team of experts. It's like assembling a squad. You've got the neurologist who's fine-tuning the patient's LEMS treatment. The pulmonologist is there to test lung function because, remember, the breathing muscles are weak. The cardiologist is checking for any heart issues. And then, of course, the anesthesiologist and the oncologist are working together to coordinate the entire surgical game plan. It truly is a coordinated defense.
And this defense follows a super strict countdown. Weeks beforehand, the specialists are consulting and getting all the medications optimized. Then, the day before surgery, they run all the final clinical checks and lab tests. And on the day itself, it's all about final prep, confirming vital signs, double-checking all the equipment, and making sure an ICU bed and any emergency reversal drugs are ready to go. Absolutely nothing is left to chance.
A huge part of this playbook is knowing what to stay away from. And this isn't just a suggestion. This is a red flag list. For example, certain common antibiotics can actually make the muscle weakness worse. Magnesium, which is given all the time in hospitals, is a massive no-go because it directly messes with that already faulty nerve signal. Heck, even a simple infection can cause a complete collapse in the patient's muscle strength.
Okay, so now we're entering the operating room, and this is where it all comes together. This is where the anesthesiologist has to perform this incredibly careful tightrope walk, balancing the need to keep the patient under with their extreme sensitivity. So the team is staring at two main paths. The preferred route, if the surgery allows for it, is what's called regional anesthesia. Think of a spinal or an epidural block. This is way safer because it just numbs one part of the body, which lets the patient keep breathing on their own and avoids a lot of those high-risk drugs. But for major operations, that's not an option. You have to go with general anesthesia. And that is where that tightrope walk becomes truly, truly perilous.
This brings us to the one guiding principle that shapes every single decision from this moment on. The one golden rule for putting a LEMS patient under anesthesia. Any guesses what it might be?
Avoid muscle relaxants. I mean, at all costs. The source material could not be more clear on this point. These drugs, which are totally standard in almost every other surgery, would completely block the already weak nerve signals. For a LEMS patient, that could mean prolonged, catastrophic paralysis and, critically, an inability to breathe on their own.
But what if, for some reason, they are absolutely unavoidable? Well, then, the protocol is unbelievably strict. They have to use a very specific type that can be reversed, and even then, they're only using a tiny fraction, like 10 to 20% of a standard dose. They give it incredibly slowly, all while monitoring the muscle's response second by second. and they have to have a special reversal drug called Sugamedics right there in the room, ready for immediate use.
So how do they actually monitor the muscle function so precisely? They use this cool device that sends 4 little electrical pulses to a nerve and then measures the strength of the muscle's twitch in response. It's called a train of 4, or TOF monitor. Now, a fully recovered muscle gives a response ratio of 0.9 or higher. That number, 0.9, that is the magic number. It is the objective, undeniable proof the team needs before they can even think about letting the patient breathe on their own again.
All right, the surgery itself is over, but that tightrope is still going. For a LEMS patient, the danger is far from past. The recovery period is every bit as critical as the operation was.
Taking out the breathing tube, that's called extubation, is a massive decision, and it's based on a very strict checklist. First off, that muscle response ratio, the TOF, has to be above 0.9, no exceptions. Next, they test the lung strength directly. Things like vital capacity, which is the size of a deep breath, and inspiratory force, how hard they can suck air in. Only when all those objective measures are met, and the patient is awake and their pain is under control, only then is it safe to let them fly solo.
So after extubation, the patient goes straight to the ICU for very close monitoring. The team uses a strategy called multimodal pain control. What that really means is they're using a combination of non-opioid drugs and regional nerve blocks to manage pain. And that's so important because it lets them use fewer opioids, which can dangerously slow down a respiratory system that's already fragile to begin with.
The road back to normal is very methodical. The patient's specific LEMS medications, those are the drugs that help their nerves and muscles talk to each other better, are restarted immediately. Physiotherapy starts right away too, to help strengthen their breathing muscles. And then finally, they are slowly and very carefully helped to get moving again to rebuild their overall strength.
So, after walking through this entire high-stakes journey, what's the big takeaway here? What's the main thing to remember?
Ultimately, what this whole story shows is how you meet a super complex, high-risk problem with an even more sophisticated and coordinated solution. It's a fantastic example of proactive defense, not reactive treatment. By thinking ahead, by anticipating every single potential problem and building a specific plan for each one, the medical team transforms what could be a life-threatening disaster into a manageable recovery.
And this leaves us with a pretty big final thought. The incredible, detailed planning required for this one rare disease just highlights the immense power of integrated, team-based medicine. It really makes you stop and wonder, how can we make this amazing level of coordinated, proactive defense the standard of care for every single person who's facing a rare and complex health challenge?